Welcome, everybody, to the first meeting in 2024 of the Medicaid Client Voice Council. I hope you're enjoying our new space. AFMC did a great job renovating this space, and it's got all of the latest technology. We've got all the guys in the back running the sound and the online presence. Welcome to all of you who are online watching as part of this presentation. Welcome to our returning members, and welcome to our new members. We've still got a couple members battling fog. They let me know via text they're going to be here in a few minutes, but we're going to get going without them because we have a full agenda. A couple housekeeping items. Hopefully when you came in, you saw the bathrooms. They're right outside this door. When we break for lunch will be served in the room here at the back. And there are some women who have Ask Me buttons on. If you do have any questions about anything related to the facility, they work here. They can answer those questions. So look for a lady with the Ask Me button. Later in the meeting, we are going to elect a vice chairperson. Any of the new council members who want to be vice chairperson, just think about what your sales pitch will be to the members, because the council members will elect that vice chairperson. Last year, Kristen Arnold raised her hand and made a pitch to be the vice chairperson, and because she was elected by her fellow council members, she is now our new chairperson for the Medicaid Client Voice Council this year. So, Kristen, you've got a microphone there. Yes, welcome. If you'd like to share some opening comments for your fellow council members and those in the room, feel free.
Good afternoon. Like Jason said, my name is Kristen Arnold. I'm very excited about this year. I can't believe that it's already a year past. It's crazy. We did great things last year, so I'm very excited about what we're gonna, make a little bit better this year. I'm up for any ideas of how we can improve, and if anybody wants to be vice chair, talk to me.
All right, thank you, Kristen. It's a busy day at the Capitol. It's a busy day in state government in general, which is going to cause us to shuffle our agenda a little bit. What you'll see after lunch on your agenda is a item that says MCVC input. There will be times that the leadership at DHS wants your input on things that we're going to present to the public before we present them to the public. That includes a couple of flyers that I emailed you yesterday. If you didn't get a chance to review them, they're also on the table in front of you. And so Melissa Weatherton is director of the Division of Developmental Disabilities. She is going to present to you what these slides are, or what these flyers are, and I've also emailed them to our former council members so they can have input as well. But you here in the room get the first chance to offer her some input on these. So Melissa, if you'd like to walk them through it and see what
Is there a
suggestions
slide
they
deck, Jason?
There is, yes.
Okay. Hey guys, so since last year I switched jobs. I'm over specialty populations now, so even more fun. And the interim DD director is not here because I think we forgot to invite him. But his name is Tommy Tarpley, and he was my deputy for about 7 years, and he's the interim DD director. In case any of you guys need to get a hold of him. And we'll be sure to invite him next time. Under my new role, I still get to do a lot of things I was doing before, including overseeing Medicaid's American Rescue Plan Act project. So this was money, for those of you who are new, during COVID, the federal government put out a federal reg called, it's the code citation is 9817 of the American Rescue Plan Act. And that federal citation allowed each state's Medicaid to apply for a pretty significant amount of federal funding. It's very specific on how it can be used. It cannot be used to do construction or renovation or build things. It can't be used for hospitals or institutional settings. It has to be used on expanding and enhancing our home and community-based services. And for those of you new people, because I know y'all don't have much baseline yet, but we perform in Medicaid home and community-based services through programs called waivers. So, and that's a very simplistic way of, it's a little bit more complicated than that, but it's a very simplistic way to understand it. These are services that require a higher eligibility criteria to participate in the waiver program. So we operate a lot of waivers at the department. We operate what people call the DD waiver, but that's actually not the name of it. It's the Community and Employment Supports waiver. And that takes care of about 7,000 people with intellectual disabilities. We have a very tailored autism waiver program that takes care of children up to age 8. There's 180 kids in that program. We have waivers for those people that are aging, elderly, and physically disabled. So one is called AR Choices. And that's a waiver for aging and physically disabled that goes into people's homes to help them. We have something called Living Choices, which is our assisted living waiver. So we have 1,200 assisted living slots in that waiver. And if you're on that, Medicaid will pay for you to go to an assisted living facility. We have a program called PACE, which is an all-inclusive care for the elderly. We have a self-direction program that is called Independent Choices, also a waiver program. And just not to totally get down the weeds, but TEFRA is a waiver program. That's what allows us to have people pay in that make too much money to qualify for Medicaid. And our non-emergency transportation is under a waiver program. And our behavioral health services under the PASS is in a program very, very similar to a waiver. All right. So those programs are eligible to receive this funding to expand and enhance services available under those waiver programs. In addition to those waivers, the federal government also lets us utilize this money for home health and personal care, because they are considered also, even though they're not in a waiver, they're considered to be home and community-based services where people are going in to help people. So we have so many projects going on under this funding stream right now. And I'm not even here to talk about all of those, but hopefully I can get back on the agenda and we can pass out that initiative list. I think the last time I looked, we were doing 17 initiatives to expand or enhance our home-based services under this funding stream. But today, what I'm here to talk about is the Home and Community-Based Education Initiative. This has really come out of a lot of the work the council has done, and then also just seeing a lot of disdain on social media. So, you know, we understand that Medicaid is extremely complicated and that we oftentimes do not explain it very well. Where's the little clicker? Any ideas? Is this it? Looks like a little walkie-talkie.
Try clicking the green and see.
Yep. Okay. All right. And guys, this rating is so small, I'm going to have to read it off of this. There's no way I can see that. So let me get my mic over here. So here's what we're doing with this initiative. So,
There's a handout too.
oh, that'd be better. Let me switch over. Okay. Okay. So with this initiative, we are spending these federal American Rescue Plan dollars to develop a robust educational campaign to try to better explain Medicaid to our beneficiaries and honestly, even our own internal staff in some respects, right? Because each division is so used to doing their own thing that they don't understand how it overlaps. And we also feel like because of this, we bounce a bunch of people around. So we're doing a couple of things in this space I'll talk about that is correlates to this. It's not in this plan to try to stop that bouncing. So, but the goal of this educational campaign is just to ensure that not only are you getting information that makes sense, but that you're getting information that's accurate, right, and consistent, because sometimes it just depends on who you get on the phone what kind of information you get, because it's very hard to keep our 7,000 plus staff informed of everything that's going on across the department. We also have recognized that our website could be better, could be a little bit more friendly, right? It could be easier to find things. So we also have a dedicated staff member right now going through every single page of our website and every link and making a spreadsheet of overall changes that we want to make. So this is the list I went through, and that you have this handout, I believe. But these are all of our programs in this left-hand box that I just walked through that allow us to provide home and community-based services. And these are the programs that are eligible for this enhanced or expansion funding. So what we're trying to do in 2024 is kick off this campaign. And what we're starting with is just, very simplistically, one-pagers, right? One-pagers that really go through each one of, let's see if I can go back. Each one of these programs is what we're starting with, right? That explain what these programs are, how you qualify for them, who the clientele is, and what you can get in these programs, so that there's a place where you can better understand the differences in how you qualify and what you can get. Because oftentimes you don't even know what services are available under these programs, right? And so trying to start with these one-pagers, which I think you have the first versions in front of you. And this one in particular, just very simplistically, what is Arkansas Medicaid? All right? Because, it's not as simple as you would think, right? A lot of people think we run Medicare. We don't run Medicare, right? The federal government runs Medicare. We also don't run Social Security, right? That's also the feds. So it's trying just to be very simplistic on what's the difference between Medicaid and what's the difference between Medicare. And as you guys know, a lot of our clients are on both, which makes it even a little bit more confusing. So we are just looking for feedback in terms of, does this make sense, right? Are we missing something? Is there something that you think, when you get to looking at it, is there something that you think would help the public understand the difference? And just remember, this is just like we're trying to set baseline. And then from this point forward, the one-pagers are just going to build on it. Because you can't build on explaining a waiver if you don't understand basic Medicaid, right? So trying to set the baseline with these first couple of one-pagers. And then connected to that, what is a home and community-based service, right? Because there's a difference. Yes?
I'm looking at what you just showed us, and it says what are HB. Okay. Is there a plan to have those that you could click on those or get further information? Because that really doesn't tell me a whole lot.
I know. So the plan is we're going to put one-pagers out on each one of these boxes, and then we're actually going to shoot video of each one of these boxes to put on social media. And the ultimate goal is to get our website set up to where you go to one page to have all educational materials, right? So that you could click on these.
So what if the individual thinks they may qualify for more than one of them? How do you decide which one would best fit them? Mm-hmm. And how do they know who to go to ask which one would fit me best?
That's a great question. So I mentioned with this money in this campaign, we're using that federal funding. We're also working on streamlining how our phone numbers work. I guess it's a very simplistic way of saying that. So on each one of our one-pagers from this point forward, it will have a singular phone number, all right? So what we're trying to get to is steer everyone to one website and one phone number, and then changing our contractual agreements so that our vendor answers the one number, and then they do the warm handoff to the different units, right? So that with the ultimate goal of getting them up to speed to the point where they can answer the majority of the questions. The reason this is, we've always known this is a problem. This is not a new concept. It's called no wrong door. In many states, they've implemented this, where it's a one-stop shop. You can imagine, Jason actually was initially hired under Secretary Gillespie to kind of try to start that no wrong door concept of we would route all calls through a singular ombudsman's office. It's just not realistic, right? I mean, Jason Peterson could spend 30 years with us and never be able to answer every question that came through that singular call center, right? So what we're trying to do now is contract that function out, get one phone number, right? One 1-800 number, put it everywhere, and then do it in stages. So having over the next 7 years in the contract itself, our expectations on how many calls we think you should be able to answer without our assistance. What calls need to be tiered to a higher level supervisor at DHS, and setting up in our office that same mechanism where we can answer those questions. We had an executive team, retreat a few months ago where we do a lot of process mapping with our families to try to see our touch points with people. And, the way that we're currently set up is that you have a DD question and they refer you over to me, right? You have an aging question and we send you over to Jay Hill's shop. You have an eligibility issue and we send you over to Mary Franklin, right? You maybe have a person that's endangered and APS needs to go out and we send you to a different unit. What we're seeing when we're process mapping is not mind-blowing. I mean, these are things we knew, but we don't help individuals. Nobody ever comes to us with one problem, right? I mean, not normally. And so what we're seeing is when we process map families, we've touched them everywhere, right? We have an aging mother at the house that should be on AR choices, right? We have a woman or a dad that's lost their job that we need to connect with trying to get job training, right? They have a child that has autism. I mean, it's like we've got to change our model to help family units internally and externally. So that is the goal of some of this, is really we're starting from ground zero, because you guys know you cannot go to our website and find baseline information. I mean, we are aware. Mary and I have been, and Elizabeth have been on a bunch of calls. We're just a little bit appalled, right, on when we go back and see some of the stuff that's on there that's so old, because we never had a dedicated team that's like, your job is to keep information up to date, right? So like, if you go on there and look at PASS, what's on there for PASS is stuff Paula Stone and I wrote in 2017 and Dennis Smith, right? Now some of it's accurate. I mean, right? Like the concept's accurate. But there's just been changes. And so we've got to make an effort. And this is where we're starting, right? On the one-pagers, turning them into videos, turning them into a website.
And there will be more one-pagers that you'll be reviewing in the future. These are just the first two. This was a great place to start. So if you've had a chance to look them over, council members, do you have any suggestions or things that you see on the one-pagers? And if you haven't had a chance, you can email them to me later and I can relay them to Melissa. But if you have any
Or if you're old school like me, you can like handwrite comments on them. And then give them to me.
I don't have any additional questions. It's just that I'm excited that you're trying to make, make this effort. For perspective, my son is 36, and the same things we're talking about now, when he was 3, we were talking about. And so I know that, I understand all of that, and I understand how complicated it is. I just hope that it continues on a more quicker scale, because there are people in crisis now. I mean, they're not in crisis 7 years from now or next week or next month. So I'm hoping that it happens more timely.
And I agree with you.
And I was just going to say, if you'll look at the one-pager, sorry, I'm
Get
jumping
on
in.
there.
You'll see two different versions. One is a more simplified version, and one's a more detailed version. And so one of the pieces of feedback we would love to get from you all is, what do you think should be out there? Should it be simplified or the more detailed version? The way we're looking at it right now is externally would be the more simplified version. Internally for our staff would be the the more detailed version, but we would love your thoughts and feedback on if you think that works or we should put more details out for the public.
Oh, and the last thing I will add is that we are also going to take these one-pagers, and we are working, Amy's really helping with this initiative. We're working on using these one-pagers to I'm not going to call it a quiz, because that sounds punitive, but we're going to call it like a learning tool, right? And so anyone that is hired on in one of our Medicaid divisions, or even some of our staff that's already there, right, is having them take this kind of learning quiz once we get done with all these one-pagers to see where we need to focus on internal training more as well. Because, like I said, one of the downfalls I'm sure y'all have noticed is that, there's us that you see all the time, right, and then our next layers. But then after that, it gets really hard to keep people up to speed when we're changing things all the time. And so trying to make sure that we also have an evergreen training document that is with this whole package from this point forward.
All right.
Okay.
Thank you, Melissa.
Thank y'all.
So in keeping with the theme of juggling the agenda, we're going to go to what was scheduled for 11:40, the reentry waiver presentation. Part of the purpose of this council is to learn about and possibly improve programs and proposals at DHS. Next month, DHS plans to seek a federal waiver from the Center for Medicaid Services. If approved, it will allow Medicaid to cover services for reentry for people leaving prisons, jails, and the custody of the Division of Youth Services. It would also allow Medicaid to pay psychiatric hospitals. So here to share more about this requested waiver and the reasons for it is the former director of the Arkansas Medicaid Control Center, Amy Webb. We also open this part of the meeting up to our folks who may be watching online. This is a public forum about this change, so if they have any questions, we're going to have a spot in this presentation where they can enter their name in a chat box online, and we will call on them. But Amy, let's learn more about this approach to reentry.
Move the microphone way down. Hey, good morning, everybody. I'm Amy Webb, and what Jason said of my title, also interim deputy director for the Office of Substance Abuse and Mental Health. First, I want to recognize Secretary Putnam. She snuck in the back there, so I wanted to make sure you all knew that she was here. And I'm actually presenting today on behalf of Paula Stone, who's the director for the Office of Substance Abuse and Mental Health, and she got pulled to go to Northwest today. So, and Dennis Smith who is a Medicaid advisor for the state, will help me answer any questions if I don't know the answers. So first I just want to say that since this is a public hearing, I will be reading the slides, so I make sure and cover everything and I don't miss anything. If people want to access the waiver, they can go to our website at humanservices.arkansas.gov, and if they want to submit public comments, you can email those to orp@dhs.arkansas.gov. Okay, where is the clicker? All right, so this is actually a really exciting opportunity, and I'm excited to be able to work on this with Dennis and the OSAM team. So currently, the way that Medicaid is set up, if someone goes to jail or prison or are placed in the custody of the Division of Youth Services and they're on Medicaid, we suspend their Medicaid when they go in. Medicaid does not pay for stuff while they're incarcerated. The same thing is true for people who go into an institution of mental disease, like the Arkansas State Hospital. But recently, the federal government has put guidelines out that allow states to do something different. And Arkansas is requesting to participate in this new approach. We put out for public comment our draft waiver. I think it's out for public comment through next week, and you can find it on our website. But it allows states to keep people's Medicaid turned on for a limited period of time. And the way this will work is we submit this to the federal government, and then they can make changes to what we've requested, and ultimately we'll settle on terms and conditions for the waiver. I said I was going to follow the slides, and I immediately started talking off the slides. So this opportunity coincides with a new federal law that requires Medicaid to begin in January of 2025 to provide certain services for justice-involved youth. So those are our youth services kids who come into our care and are at our treatment facilities, for example. So 30 days before they leave, the law requires that we do some basic screening and diagnostic testing. And at least 30 days after, we also have to do some targeted case management for those individuals. So we're kind of tackling those two things together, both the federal law and then the opportunity related to incarceration and IMD. So DHS is requesting that the federal government allow Medicaid to cover medically necessary services for inmates and adults in IMD patients. And we'll do that for 90 days after incarceration, 90 days before release from a carceral setting. And during these periods, Medicaid would pay for all medically necessary services. We would also enroll individuals in the PASS on the back end and possibly provide them home and community-based services. It will also allows Medicaid reimbursement for treatment by an IMD for up to 90 days. Again, that's based on medical necessity. So we're calling this the ARCH program. We played with a lot of different names, but really we like this because it kind of represents a bridge. And what we want this program to be is a bridge back into the community and help us fill in gaps in services, create a continuum of care for these individuals, and provide a smoother transition upon reentering communities. And what we know so far from the research and data is that a lot of the individuals who are incarcerated have significant health needs, a lot of chronic health conditions. So we hope that this will help improve their health outcomes, also reduce inmate recidivism, and that is connected to inmates who may have substance abuse or mental health issues that are untreated. So if you can work to get those treated and keep those people taking their medications, we could reduce recidivism. Same goes for reducing preventable emergency room visits, reduce deaths, better support our IMD workforce, and promote efficiency and effectiveness in the Medicaid program. Again, a good example of that is the preventable emergency room visits. If we can keep people medicated, following their treatment plan, getting the supports and services they need, then that keeps Medicaid from paying for preventable emergency room visits. So as I said, there are a lot of health-related needs for these populations. We see higher rates of mental illness, substance abuse, chronic health conditions, and then all of these really contribute to ongoing poverty for this population, incarceration and recidivism, and also poor health outcomes. So for this new program, we would be talking about multiple carceral settings. So it would be the Arkansas State Hospital Adult Forensic Units, the Division of Youth Services facilities. I think there are 5 juvenile treatment centers in the state, a secured restoration program that we get up and running, and then the correctional facilities. So that includes state prisons, local jails, and then county-run juvenile detention facilities. It does not include federal prison. It also will include existing IMDs that are enrolled in Medicaid that are adult units within psychiatric hospitals. One of the things that this will require the state to add to our services is adult residential substance abuse services. That is not something that Medicaid pays for today. And so we would be working through the process of getting those providers enrolled and then including that service in the state plan. Again, so what we're proposing, this is just kind of a boiled down version, is so up to 90 days of Medicaid, and then it would be suspended on the 91st day. And that is if they're already enrolled in the program. If they're not currently enrolled in Medicaid, then we would do that on the back end. And because it takes a little bit of time to get your Medicaid application through, we would start that 135 days before release with the goal of having Medicaid in place, an independent assessment if we need that, and a pass in place if we need that before they are released. Oh, and I accidentally took this out because it's the same thing, so I'll skip that. And then, so next steps, so public comment is through January 31st. And then we're doing stakeholder presentations. We've already been meeting with the Sheriff's Association, the Association of Arkansas Counties, the Association of Jail Administrators, the Department of Corrections, and we'll be continuing those stakeholder discussions. And really, those are in-depth, how do we start the implementation? And it's going to take all of us at the table to do that. And then we plan to submit to CMS no later than March 1st. And again, we'll go through negotiations with them. And so what we proposed could change. With the goal, we're going to be very optimistic and have a goal of approval on July 1st of 2024 with a January 1 implementation date for the first phase. We will have to phase this in. So we'll be working on all of that through this process. And then we want to open it up for anyone online to ask any questions.
Let's start with council members first, and then we'll go to our online viewers. Any council members who have a question? Okay. Betty?
The first thing that comes to mind is I understand that you're meeting with all the county and state and all those individuals, but when it gets down to the person who's incarcerated, how do they connect if they don't have anybody come to them? In other words, you know, obviously the people who are in charge know, but you know, as we all know, sometimes things don't filter down to the people that walk through the door. So, you know, how do we make sure we cover those? I mean, I know it's not something you could answer today, but that's something to keep in mind is how do those people get identified and connected?
Yeah, no, and I think that's a really good point, and we do want to not just talk to the people at the top. We want to talk to people all the way through so that we get their feedback and experiences, and we do plan to do that. We're starting those conversations with Department of Corrections and how that will work, and we're going to be learning a lot during the implementation phase or the creation of the implementation plan. So hopefully we'll know more about how to make that work well.
And my question kind of piggybacks off of hers is, once they're getting ready to leave, do they have like a counselor or a past support person to follow them and help them and keep up with them as they're continually to try to be successful
Yes,
after
I'll
leaving
answer
the program?
this, and then Dennis, if I misspeak, you tell me. But the plan is for those individuals who needed to go into a pass, they'll have a care coordinator, just like people in the past do today. And our hope is they'll help them stay connected to the services they need, so that they aren't navigating that completely alone. So, I mean, that's the ideal state, is for the pass to work very similar to how it works today with those individuals.
And for our online viewers, if you have a question or a comment about this, put your name in the chat. We have a DHS employee monitoring this feed, and he can let me know about your question, and we'll allow you to ask that. Any other questions in the room from either members of the gallery or our council members about this proposal? No. Gavin, anybody online?
Nobody has responded yet.
Okay, well, we'll keep an eye on that. We'll move on to the next part, but we'll keep an eye on those online questions. Amy, thank you.
All right, thanks.
Appreciate it. Don't go too far, though, because we are now going to enter the Medicaid 101. Every first council meeting, we have half of the council members who are new, half who are returning, and it's always nice to have a kind of a primer of Medicaid, for those, especially for those who are new to the council. Medicaid 101, we will after lunch, introduce all of you members, especially the new members, but also the returning members. We'll have introductions. We'll have the election of the vice chairperson. But now, before lunch, we've got 20 minutes to talk about Medicaid 101. So if Amy could come back up, as well as Elizabeth Pittman, DMS Director, and we can go through the Medicaid 101 presentation. Oh, it looks like Amy's gonna. She's bowing out, okay.
Amy's had enough talking for one day, I guess. Hi, I'm Elizabeth, and I am addicted to coffee, and I've already spilled it on my slides, so nice to meet you. It's like I'm an AA. All right, I am going to attempt to explain Medicaid to you as best I can. If I talk too fast or use too many acronyms, please let me know, because I find that when you work in something every day, you forget that not everybody else knows your alphabet soup. And we do have that at DHS, so just let me know. And I am going to attempt to work the slides. I was a lawyer for a reason. It's because I don't do technology or math, so pardon me if I break this. All right, so the first thing is Medicare versus Medicaid, and Melissa talked to you a little bit about this. But this is one of the most common things. I get questions all the time about Medicare benefits, and we don't do Medicare. Medicare is a federally administered program, so no state runs their own Medicare program. All states run their own Medicaid program. All 50 states and I think like 7 or 8 territories have their own Medicaid program. Federal government is the partner for the Medicaid program, but each state has a different program, and there's a famous saying in Medicaid, if you know one Medicaid state, you know one Medicaid state. They're all very different. So just because you understand Arkansas Medicaid doesn't mean you can go to Memphis and understand Tennessee's. And that's just part of the fun. So Medicare mostly serves people 65 and older. So when you hit 65, you apply for your Medicare benefits. That's what most people know it as. There's a few other populations that it does cover, people with end-stage renal disease, blind. But that's primarily it's 65 and over, and that's probably what you've heard of. They provide basically the same benefits to all recipients, regardless of what state they live in. And that's what I was saying, is it's federally administered. So Medicare looks the same across the country for the most part. And the funding is paid directly to the providers, just like health insurance. Overall, there are a few exceptions to that, but we don't have to get into that. But just like traditional Medicaid, you bill directly to Medicare when you're a provider and you're seeing a patient with Medicare. You may have also heard of a Medicare Advantage plan. That's their version of managed care, which we have in our PASS system here, where you bill the managed care company, like your Blue Cross Blue Shield, for those Medicare services, and they provide those. Medicaid, on the other hand, is a state-run assistance program, typically known to be for those with low income, but it is also serves individuals with disability, and that can be developmental disability, it can be a mental health or serious mental illness or substance use disorder. Can be a physical disability. It is jointly funded by the federal government. Here in Arkansas, we get a 71% match rate, I believe. So for every dollar we spend, the feds give us 70 cents. We pay 30. So we have a really good match rate. Some states have a match rate as low as 50%. So states that have a higher income level pay more in state general revenue to fund their Medicaid program. And we have different match rates, so that 71 is the standard, but we have some programs that have 90%, we have some that have 80-something, so that's why you see that average being a little bit higher there. And like I said, programs vary from state to state, but we have federal guidelines that we have to fit into, so you'll often hear us say we didn't get CMS approval, or CMS is making us do something. That's the Centers for Medicare and Medicaid Services. They've added some words to it, but that's good enough. They have to approve our decisions, our policies, and agree that they are in line with those guidelines. So that's what we mean. They do have certain waivers, and we're going to get into that, of those guidelines. And then we pay directly to the providers in traditional fee-for-service. And like I said, we also run some managed care programs. Pretty much every Medicaid member here in Arkansas is enrolled in dental managed care. So if you receive dental services through Medicaid, that's primarily through a managed care company. And we have about 40,000 now enrollees enrolled in something called PASS, Provider-Led Arkansas Shared Savings Entity, which is a managed care program for those with developmental or intellectual disability or behavioral health needs. That's a managed care program like Medicare Advantage. All right, so how do we update the Medicaid program? We have two main ways we do this: a state plan amendment and a waiver request. Our state plan is our agreement with the federal government on how we'll provide Medicaid services in the state of Arkansas. That's what that is. It is over 1,000 pages. So if you really need to go to sleep one night, pull that sucker up. It's a snoozer. But that is how we tell CMS what we plan to cover for people here in the state of Arkansas. And so when we want to change it, we have to do what's called a state plan amendment, submit it to CMS for approval. Typically, we'll put that out for public comment for everyone to comment on. We'll also take it to the legislature to review and approve, and that's per a state law that requires us to do so. So that's how we do that. CMS gets 90 days to approve that. That's their standard time frame. CMS is really slow, so they also do something they like to call stopping the clock, which means we can't get it done in 90 days, so we're going to stop this and give ourselves more time. So once we change the state plan, it is permanent until we go in and change it again. Sometimes CMS tells us we have to change the state plan, so we'll come to you with some of that stuff too. And sometimes it's because we want to. The waiver, there are several different types of waivers, but in general, that just means we are asking for permission to not follow the standard CMS rules. For example, in the developmental disabilities waiver, the community and employment supports waiver, we provide certain services to those beneficiaries because they meet a certain need, a medical criteria, but we can cap the number of people who are enrolled in that. We've waived that requirement of CMS that anybody that's eligible can receive those services through that waiver. That's how that works. So there are those 1915C waivers. That's like the developmental disabilities waiver. We have 1915B waivers. Those are managed care waivers like PASS, and that just allows us to put people in a managed care plan. And then we have what's called an 1115 demonstration waiver. These are the three main types. That waiver is a little more broad-based. It's a demonstration waiver because it's us asking CMS to do something pretty innovative, like our home, buying private insurance for individuals that no other state's doing. We're the only ones. But we have to show them that it's working. And that's why it's called a demonstration waiver. Waivers typically last for 2 to 5 years, but we can ask to renew them. And so that's how that works. So we'll submit renewal waivers about on a 5-year cycle for most of these. And we are required to show that when we do this waiver, we're not really spending more money than what we would spend if we did a regular state plan. So that is one of CMS's requirements. And they call that different things because CMS just likes a bunch of different words, but that's pretty much what that means. All right, Mary can probably answer more questions about this than I can, to be completely honest. So if you have questions about this slide, I'll direct them to Mary. But this tells you what our beneficiary categories are and how many are enrolled in them. And you see we have the majority of our beneficiaries are children served through Our Kids A or Our Kids B. Our Kids B is our state children's health insurance plan. It's expanded Medicaid. It's not technically Medicaid, but it's very similar. And it goes up to, I don't remember the percent of poverty for that one. 206. See, that's why Dennis and Mary are there. And then Our Kids A is our traditional Medicaid for children. Our Home is our expansion that serves adults 19 through 64 in that private insurance program where we buy private insurance policies for those individuals. Parent caretaker is what we had before we expanded Medicaid. As you can tell, we only serve about 46,000 adults in that. We now serve 250,000 through Our Home. It's a very, very low federal poverty level. It's 17% of the federal poverty level. I don't remember the dollar amount of that, but it's very, very low income that we were serving prior. And so there's very few adults on that. When we expanded Medicaid, as you can see, I can't do math like I said, but we greatly expanded our population. SSI Medicaid, this is why people think we do Social Security a lot of times, but if you get Social Security disability, you get Medicaid with it, and that's what that is. And Mary can answer those questions too. Sorry, Mary. Newborns, we cover automatically up to 1 year, and then they can transition into Our Kids A or B. We have a skilled nursing facility eligibility, so when you meet the medical criteria and financial criteria for skilled nursing facility services, You can then receive Medicaid. Medicare does not pay for long-term skilled nursing. I think it's a 60-day benefit in Medicare. So adults who need long-term nursing often come onto Medicaid. Medicare savings are people that are dually eligible. DDS waiver, autism, and TEFRA. TEFRA is not specifically for children with intellectual or developmental disabilities. It's for any medically needy children, but the majority of children on that are children with developmental or intellectual disability, and I cannot ever remember what TEFRA stands for. It's like the tax equity. It has nothing to do with the eligibility category. So TEFRA is for children who have medical needs. It allows the parent, if they exceed certain income thresholds, to buy into Medicaid, and they pay a premium every month to purchase Medicaid services, because Medicaid often covers things that traditional insurance does not, like rehabilitative therapies for children. So children can get OT, PT, or speech, 90, 100 minutes a week, 120. Traditional insurance doesn't cover that. AR choices or living choices waiver if you qualify for a skilled nursing facility but you don't want to go into a skilled nursing facility. We offer home and community-based services. That's the AR choices waiver. We also offer assisted living services, which is the living choices waiver. And then children who go into the foster care or adoption system are also eligible for Medicaid. I'm sorry, I have a bit of a cold, so pardon this voice. Oh, this is what these numbers were for. Okay, so the number of enrolled and active providers, as you can tell, is 131,500 providers. That's such a large number because as of 2020, I believe, we had to start enrolling direct service providers in in-home services. So if you have somebody coming into your home to provide what we call personal care, which is where they are basically an attendant for you and they help you with your activities of daily living, we now have to enroll that person. And so that's why that number skyrocketed so high. The number that are actually billing us is a little over 10,000. And then we have 88 different provider types. One of those, though, is what we call provider type 95, which is a non-billing provider. And so that includes a lot of different provider types in there. All right. Pretty much all clients have to meet an income threshold. They're different for the different categories, but pretty much all of our categories have an income threshold, ranging from 20% to 250%, depending on the category. Some benefits, like the waivers, have a what they call an income of 1. So if your child is qualifying, we look at their income. So children typically don't have income. So that's one reason children qualify for those much easier. Limits are typically higher for children, pregnant women, and LTSS services are like SNFs, waivers, those types of things. Things where you're going to need the service for a very long time, probably for the rest of your life. We redetermine eligibility every year. You are required to report changes in circumstances within 10 days. That doesn't happen all the time, but that is a requirement. We understand that. I'm not great at reporting changes in my circumstances either. And then clients of LTSS must meet asset limits in addition to income limits, and that's like your bank account, how much money do you have in it, that type of thing. And then you also have to meet an institutional level of care. These are the annual eligibility limits. I think you have this. You may need a magnifying glass to read it. I'm sorry. We should probably send these to you. And that is it. That's a very brief overview. If you have any questions, let me know. I tried to make it a little less boring because I know it kind of is. But.
And I will send the slideshow out to you, your email, if I didn't already. I think I may have already sent that one. Yeah. But some of the other ones came in late, and I apologize I didn't get them to you in advance of coming to the meeting, which I like to do, and which you like to get because you told me that. Any questions about Medicaid 101? Kind of a get you ready for the year. Now you understand Medicaid. You can help us make it better. All right, before we break for lunch, I think Amy acknowledged the presence of our secretary. Secretary Christy Putnam is with us, and I wanted to invite her up. She would for sure like to welcome the new members, of course, welcome the returning members, and probably just say a few inspiring words for us all.
Thanks, Jason. Thanks to the DHS team for putting these together. And I do want to say welcome to everybody. Good to see familiar faces, but we're also very excited to have new members. Just want to thank you for giving of your time to help us make Medicaid better, to Jason's point. He said you know Medicaid now, but remember that's only in Arkansas. You only know Medicaid in one state now. So it really is true, having worked in Florida and Kentucky before coming to Arkansas, Medicaid is vastly different from state to state, and it's just really complicated. So thank you for taking time to learn it with us. We really do value this venue as a feedback mechanism for us. We get a lot of great suggestions. We hear, in real time, real information about what you all have experienced going through some of our processes, and it helps us to understand a little bit better. Sometimes, we're a little bit removed from some of the frontline staff and some of the things that go on, and so we try to get out a lot. Our team gets out a lot into the county offices and with our providers, so that's another way that we try to stay connected to what's going on and where we have issues that we can really rapidly identify and get past them. But just again, wanted to say briefly welcome. I know I'm standing between everybody and lunch, so you never want to be in that position. One of the things, our goals for the department as a whole are we're really working on prevention. We're really working to improve Medicaid and its sustainability. We're focused on behavioral health and making sure that we've got some gaps in our behavioral health system. So we definitely we're taking a look at that, and we have some exciting new developments in that, and that's why I have to leave. So I apologize, but it's exciting. It's for a good cause. And then the last thing is we want to make sure that we're constantly looking at improving our employee experience, because DHS is a hard place to work. We do hard stuff, is what I say DHS stands for, is doing hard stuff. So we are here to do hard stuff with you, to learn from you, to grow with you, and again, just really appreciate your time. Thank you so much.
Thank you, Secretary Putnam. So we're going to break for lunch. 3 of you are new members. You get to get your photo taken today. So you're going to go with Stephen over to the other building. We have a special room where we'll bring you, and then you can have your lunch. I thought you'd want to have your photo taken first so you don't have lettuce in your teeth for your photo. So you 3 will go with Stephen. The rest of you, we will break for lunch. We'll have a half an hour. And then also, if you want to introduce yourself to Kristen, new members, when you get back, and possibly talk about being the vice chairperson, and see, you want to. So after lunch, we will meet the new members, we'll meet the returning members, and we will allow an election for a vice chairperson. So we will see you in 30. We've been juggling the agenda consistently, so we're going to stay consistent. We're going to lose some of our DHS leadership to government meetings, things at the Capitol, things going on. Some of them are going to have to leave in a half an hour or be at a meeting at 1. So while we have the institutional knowledge in the room, we're going to skip ahead to the open discussion question that we have on every agenda. For new people, this is an opportunity for you to ask a question that was not on the agenda, anything Medicaid related. Anything that would interest people who receive Medicaid, who provide Medicaid, any question from members of the Medicaid Client Voice Council that you want. And we have leadership in the room that can hopefully answer it. If not, I will jot your question down and I will get an answer for you. I'll find the right people who can answer your question. So are there any questions from council members on any Medicaid related topics? Yes.
I'm curious to know what drives the numbers, or what determines your caps on these different waivers. For instance, the cap on 12,000 patients for SNFs, and what the numbers that make up your ALF and your SNFs specifically.
So is that the chart in there? So not every an eligibility category doesn't necessarily have a cap. Waivers have caps. We don't have a cap on skilled nursing facility eligibility. We do on the living choices and AR choices waivers, because they are a waiver. I don't think we've hit those caps, have we?
We still have, we're really not even close to even what our point in time. The 1,200 cap, for instance, that you referenced on living choices, that is a point in time, that is any given day. Over the course of the year, that waiver has a space of 1,725 positions available. So, but to Elizabeth's point, because it is a waiver, it is outside of state plan. They are based on projections around usage with our state and the enrollment that we'll have over a period of a year. But the 1,200 and most of our waivers do have both point in time, which is any given day, but again, over the course of the year, those caps, the actual cap is quite a bit higher. In this case, Living Choices at 1,700.
So when they talk about a slot, they're having to wait for a slot. When they're having to wait for a slot to open up when they've been approved for a particular benefit, and they're having to wait for a slot to open up, is that dependent upon those numbers?
So no, it could be. On the waiver that you referenced, for instance, Living Choices waiver, that is for persons who are on Medicaid to live in an assisted living facility. There is no wait list, and so when you are eligible to receive those waiver services. However, if you've chosen a provider that has no available beds, and that's where you want to live. You want to stay, for instance, if it's a provider in your hometown and that's where you want to be, then yes, you may have to wait until a Medicaid bed opens, because all the providers do have a finite number of beds available for those services.
And when you hear that waiting for a slot, you may be referring to the CES waiver, the Community and Employment Supports waiver. We do historically have a wait list on that waiver, and it has historically been very long. I mean, it can be as long as 10 years. That is primarily driven by budget, as many things in state government are. It's a very expensive service package to provide. We recently received some funding through the tobacco settlement, and so as of 2020 or 2021, I can't remember the exact date, but we're supposed to provide slots to everybody that was on the wait list of the date that funding got put in place. So, we are slowly working our way through that wait list, but of course, as soon as we work it down, more people sign up. So, and I think Mary also wants to say something.
But on that wait list, there's also the factor of finding staff to serve the people. That also takes a long time. I mean, as you guys probably know, that is a factor as well. Because even when you get a slot, they still have to identify staff and train the staff and all that stuff.
And I think Mary wanted to say something.
And I just wanted to clarify, you may hear from an eligibility worker, like on the assisted living waiver, the Living Choices waiver, you're approved, we're waiting for a slot, because those eligibility workers aren't the ones that track the slots and the numbers and then release those slots. But that process is happening weekly, so it's not a long wait, because we're not close to running out of slots at this point.
All right, great question. Just a reminder, because I didn't share this at the beginning of the meeting, and I usually do, for the folks who are watching online, while we can all hear each other in the room, they can't hear us unless we have a microphone. So if you have a comment, just raise your hand, whether you're a DHS staff or council member. I'll bring you a microphone, and then everyone online can hear us as well. Any other Medicaid-related questions before some of our leadership goes on to meetings? Yes.
If you are a parent that may have concerns about a facility that your child may have gone to, whether it be like a residential or an acute stay, what number would you call? Not necessarily the facility itself, but to you all.
I'm trying to look up the number for Dip Squaw, but I will say, if there's a concern that there's potential child abuse or neglect, go ahead and report that to the child abuse hotline too. But let me see if I can find.
What type of facility is it?
Residential.
So like children residential? Mm-hmm. Okay, yeah, that would be DIPSQA or the child welfare. You can also just email us and we'll get it to the right place. Because sometimes that's what that whole one phone number thing's about.
While Amy's looking that number up, any other Medicaid-related questions from council members?
Not really a question, but maybe it is a question. Recently, Medicaid and our kids recipients or AR Home were required to renew since COVID. That process was horrendous for myself and my two children. I got a letter of action notice in the mail that had like 14 different listed. You're approved for these dates, you're denied for these dates based on this income and your household size of this and this, which in turn generated Ambetter to send me out like 3 new insurance cards for insurance that I've had since January 1st. Same number, but it was like a May 1st through May 31st date that I was approved based on my household size of this and income amount of this. And I mean, it was horrendous. And then the very last thing said that my AR home was closed because I told them I no longer needed the services. Well, I didn't no longer need the services. I needed the services. I did the renewal sometime about mid-September, and about the 1st of October, I started getting all these notices. It was like every day there was another letter in the mail from a processing center in Pine Bluff stating something different. I also had a 18-year-old that turned 19 on August the 1st. So our kids, she lost it August 31st and transitioned to AR home. I mean, it was so confusing as whether, like, list her in my house with her income. Does she still count with my income, with my household size? I don't know. Anyways, in the end, she nor I ended up with coverage from October the 31st through December 31st. We had to go on the marketplace and purchase our own coverage. And my youngest child, who just turned 11 on Sunday, was switched from our kids A to our kids B because I now make too much money for a household size of 2, which is really the reason that my AR home was lost, not because I told them I didn't need the benefits. And it just, I don't know. It's a waste of paper for everybody, a waste of time. I don't know. That's just my 2 cents for what it's worth.
Hi, I'm Mary Franklin. I'm the director of the Division of County Operations. So let me start with the notice in that it was confusing and it said a lot of different things. We are starting a notice work group this month, and internally we're going to be reviewing, because we did a lot of work to try and make the notices not confusing. But now that we have seen them and we know we need, we need to do some work on them. So we're going to be reviewing those notices because we've heard similar things from other people. So we have learned sometimes you don't need to know if we approved you for this, that we also evaluated you for 5 other categories and you were denied for all of those. You really just want to know you were approved and eligible for this service. So we're going to be doing some things like that to try to streamline them. But along those lines, I would love for you to send me that feedback in writing, since you have a real live letter and you got it. And what suggestions, and what suggestions do you have where it would, that we should consider as we're looking at making these changes? Yeah.
Hold on.
The letter, or the renewal was September of 23. This letter has dates all the way back to 2022 of whether I was approved or denied, and different amounts of income. I don't know where they're coming from. Like, it's just like they just pulled them out of the air. It was so weird. Why are you going back to 2022 when I was covered then anyways? I understand probably the pandemic, and moving forward, it may not be as confusing because you're not going to have that 2.5, 3 year pandemic renewal period, non-renew, where you didn't have to renew or whatever. And right. I don't know. I was just curious, is next time when it's renewal, is it going to be simpler?
So that will be our goal. But a couple of the things you mentioned, I can tell you are, sounds to me like worker training issues. Like, I do know at one point we had an issue in our system where when we needed to move somebody from one case to another, because sometimes people reapply and they end up with more than one case in the system, and we want to get you back into one case so that it's not spread out with one category here and all of that.
Yes.
And so there was a workaround for them to use the requested closure just as an administrative way to get you back in one case in the right case. They should have suppressed that notice, though, because administratively we're just moving you around in our system. You really shouldn't have gotten that notice. They don't have to use that workaround anymore because we fixed it, but sometimes it takes a while to relearn something you were asked to do, as an interim process. So that's a training issue. And then when someone is working your case, they may have reassessed you back into the past. It could be because we were behind. Maybe you had turned in that change, or we had that information and we didn't get to it fast enough. So when we did, we wanted to make sure you had the right coverage throughout. So that could be one reason. Another reason could be a training issue. Again, somebody went back and reassessed for a prior period where they didn't need to. So I definitely appreciate your feedback. And just know that we are going to be working on it, and not just you, but any of you that have feedback on our notices or feedback on what we can do to make them better. This is a good time to start letting us know, because we're going to be working on them.
Well, the letter that I'm referring to with all the 14, 15, 16 different things came in the middle of October, and it wasn't long after that till I got this invitation, and I was like, perfect time.
Yes, yes.
So anyways, I was glad to be able to share some feedback with
Yes.
you guys on that.
Well,
And thank you.
and it's great that you saved the letters so you can share them with us. Oh, okay. Well, if you email them to me, I can get them to Marion, because
Yeah, that would be great.
to see what you're seeing.
Feedback on notices, if you would all send them to Jason.
Yeah.
And then we can have them with our work group. And then some of the changes we may be able to bring back to you all and say, it used to say this and now it says this. Is this better? You know, okay?
Sure. And Amy, did you already share the number? The number you were looking up?
I gave her my card.
Okay.
Also, during the course of this, I called the number or whatever number it is to call to get help or if you need assistance. And of course, one person tells me one thing, which generates a whole nother letter that comes. And that's saying something totally different than what that person told me. Call back and they tell me something different. And I mean, it's just so confusing, all that to navigate. And I did my renewal online, and you know, for someone who is less educated and, I don't know, doesn't know they have resources as far as online and all that, I can't imagine trying to navigate through all that. I would call myself pretty computer savvy, but obviously I was not, because it was a nightmare. And I feel for people that are less fortunate than I am.
Well, and if you have feedback on particular things you tried to do on our website through Access Arkansas, we would be interested in that too, so that we can look at what improvements we can make. Or do we need to develop better, like, online help or training materials that would help you through the process? Those are things that we can look at. We can't always change it overnight, but we can definitely work towards making those improvements. Yes, absolutely. It is. Let's see.
Any other questions from council members?
So I recently did a few change reports online. Really like it, that I can link it and then change the report there. There are some things about the change report that needs a little bit of change with
Okay.
it. Some of the questions are repetitive. And so when I do the end of it, it's like it's still not removing the person that I need to remove from the case.
Okay.
It removes everybody.
Okay.
Yeah, so I think that needs help. And then with what's the best way to, if I can't link a case to change a report, what's the best way to change, report a change?
So you're doing it online and you're having difficulty. So if, email Jason your contact information, and I have someone who can contact you and help you with your individual issue. But the general feedback is welcome too, for us to learn from and see what we can do to make improvements. We also have a paper change report form, or one that you can just get online and send to us in the county offices, and we can upload it and handle it from there. So you have options. And yes, and if you have individual eligibility concerns about your case, you are welcome to, we'll have one-on-one. You can reach out and we'll just make sure it's right. The rest of the Medicaid eligibility questions, let me introduce you to Rose Page. She is a deputy in our Office of Policy and Grant Management. Very knowledgeable, spent a lot of years working in the field in the county offices. So I've got to go, but Rose will be here to answer your questions. And if there's any that we need to take back, we'll get you your answers as a follow-up. You're welcome.
Rose will also be presenting one of our agenda items. So if you don't have any questions for her right now, she still has a reason to be with us. But if you do have any questions, any other Medicaid-related questions from our council members? Okay. All right. Then let us move into meet the council members part of our agenda. We have 3 of our new council members here, and all the rest of you are returning council members. So I'm going to start with our chairperson, Kristen. We'll meet the returning council members, then we'll meet the new council members, and then we'll elect a vice chairperson. So Kristen, what we'd like you to do is share your name, a little bit about yourself, where you're from, why you decided to join the council, just a little bit of, so we get to know you.
Thanks, Jason. My name's Kristen. I live in Conway. I have 3 boys. They keep me busy. I also am legal guardian of my brother who has intellectual disabilities and was adopted through the state through foster care. So that's near and dear to my heart. I also am a supervisor for one of the passes. And I'm very excited about this year and working with everybody and meeting the vice chair. You want to go?
My name is Etandra McClure. I live here in Little Rock, Arkansas. I'm a second-year MCVC member, and I have a household member that shares in the TEFRA program.
My name is Yolanda Traylor. This is my second year here, and I'm a mother of 2. I'm a preschool director, but I'm not here. Today was our first day back from all of this snow and ice. But I speak on behalf of family members that have mental and behavioral health, so I advocate for them.
Hey, I'm Heather Honecker. I live here in Little Rock. I have 3 kids. One of them is 5, and she has Down syndrome. And we also are TEFRA. We get TEFRA services. The reason why I'm here is similar to what you were talking about. Just kind of navigating the system is really difficult, and I want to be sure and give my daughter the best that I can. And I just think that that we can all do a good job for other people who are in our shoes.
I'll stand because I've been driving. Hi, for those of you that don't know me, my name is Michelle Pedro. I work for the Arkansas Coalition of Marshallese in Springdale, and I'm just representing a community that's been marginalized and has a lot of questions with Medicaid. Insurance is not our biggest knowledgeable thing here. Back in the islands, we don't deal with insurance, so coming here to the States, it's really confusing. And so I'm trying to alleviate any questions or concerns that they have with insurances, particularly with Medicaid.
It's a good idea to stand up because I can't see everybody's faces. My name is Betty Rayford. My son is Daniel, Daniel Rayford. He's 36, has Down syndrome. I've been working in the system or trying to work through the system for 30-something years. And so I came back to see what have we done, what do we need to still do. And all I can say is you individuals with family members or people you're familiar with, you are their voice. So for sure don't give up. Give them everything you can do. This is my 2nd year here, and it's been an experience. I'm just now kind of getting my feet wet, so I'm kind of disappointed it's not going to be more than 1 year now left, but I encourage you all to be their voice for your individuals.
My name is Angelica Yanes. This is my 2nd year. I have a toddler that has high-functioning autism, and I'm also advocating for myself that I have a chronic condition that keeps me from, just, I'm sorry, I had a blank, that I've been dealing with. It's kind of hard when you have a toddler and dealing with condition yourself. And yeah, I'm really honored that I'm the only Hispanic here that's representing the community. I live in Northwest Arkansas area.
All right, now we have 3 new members, starting with Casey.
Hi, I'm Casey Kinchin, and today's my birthday. Thank you. I live in North Little Rock. I have a 19-year-old and an 11-year-old, and my mother taught kindergarten her entire life. I followed in her footsteps since I got out of high school. I currently work at Pikeview Early Childhood Center, which is part of North Little Rock School District, as a pre-K teacher, and it is funded by federal, state, whoever it's funded by. And we work mostly with low income, so I've seen a lot of, people that what they don't know, and, lack of exposure and that type of thing. So I'd like to be a voice and, help the underserved or underprivileged or whatever. I've also worked with special needs kids with autism, and I was very fascinated with autism. And in layman terms, when I'm trying to explain TEFRA to someone, I'll tell them it's Medicaid for the wealthy, or more like it's Medicaid for people that make more money than Medicaid will allow, so for their children. And from my understanding, that TEFRA is another nightmare I don't want to be a part of. I do know someone who has a child that is on, I guess, the TEFRA waiver. The child's 11, and their number is 6,000 something, 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 if any of you know what I'm referring to. Anyways, and she was just speaking out on social media about how it's just so frustrating. And hopefully by the time he turns 18, he will have whatever it is, the services that she's trying to get, that he's 6,000 in line for. So, anyways.
My name is Rebecca Ledgerwood. We're from Cache, Arkansas, near Jonesboro. I am a mother of a totally disabled child who's 42. He's been in a wheelchair for all of his life. I gave up my job to stay home and put him in the home and community-based service program so that he would have the ability to get out and do the things in life that he would like to do. So I am very thankful for that program. But he served on the council for the first 2 years, and so I'm sort of replacing him now.
All right. Last but not least, Brandy Vaughter.
Hi, I am Brandy Vaughter. I am a board certified patient advocate. I am, I think, one of the only ones in the state of Arkansas. And I advocate for my patients, mostly senior adults. I work with patients who have traumatic brain injuries, and I am also a certified dementia practitioner and certified Alzheimer's caregiver. So Alzheimer's, it was in my family, so that's a passion of mine. And the reason why I joined this was to be able to learn more about the services that are offered here in Arkansas, and to be able to educate my patients and the people that have more difficulty understanding, and just really connecting people with the resources that they just don't know that are out there.
All right, and we do have several new members who aren't here. We'll meet them at our next meeting, which, by the way, falls in spring break, so we'll probably move that. We won't have it during spring break, but we'll let you know that. And Brandy, since you have the microphone and you've thrown your hat in the ring to be our vice chairperson, would you please let us know why you would like that title or that role?
Sure, I threw my hat in the ring, but I feel like as an advocate, and that is my profession in my ministry, I feel like I could probably bring a little bit more to the table as far as helping facilitate and gathering information, especially from the other council members, to be able to hopefully facilitate some changes and share some information with DHS and with the powers that be.
All right, well, Brandy is running unopposed, so all those in favor of Brandy being the next vice chairperson, say aye. Aye. All those opposed? Hearing none, congratulations, you are our new vice chairperson. All right, we are sailing now because we only have one other item on the agenda. We'll probably get out a little early today. we mentioned Rose is here with us. Rose is here to present the continuous eligibility for children. It's a presentation on this topic. She'll lead this discussion. You can think of your questions and ask her at the conclusion of that. So Rose, come on up and learn more about this program.
Can everybody hear me? Okay. Like Jason said, my name is Rose Page, and I am Assistant Deputy Director for the Policy Unit at DCO. I am new to this meeting today. This is my first time here, but I'm not new to DHS. I've been working with DHS for about 17 years. So I hear all your concerns, and I'm glad to hear them. We do try to make our system better and our customer service better for you. So what I have today is I'm going to talk a little bit about continuous eligibility for healthcare services for children under the age of 19. And I do have this PowerPoint. I don't know if you want me to read it word for word. I don't really know how you guys do that, but I'm going to go over some of the high points, and you can ask any questions that you have. Okay, so what is continuous eligibility for children? Basically what this is effective this year, effective January 1st, any children under the age of 19 who receives Medicaid coverage, who has been approved for Medicaid, will receive 12 months of continuous coverage. Does not matter what the circumstances are. If there's any changes, if your income changes, your disability changes, you are still going to be entitled to those 12 months. Previously in Arkansas, we were already doing this with two categories, newborn and RKids B. That means that if your child was receiving RKids B coverage and you were approved in January and your income went up in June, we leave it open. We leave that category open for your child, that coverage, until 12/31 of that same year. Now what we've done, we did the same for newborn. Your newborn was entitled to 12 months of coverage, does not matter the change that happened. What we've adopted now, effective this year, is all children. Most of our Medicaid categories now, if your child is under 19, will fall under that guidance. They will receive 12 months of continuous eligibility. We do have a few instances that we will close a case. That will be if your child moves from the state of Arkansas, if you request us to close your coverage, if the child has died, and if they're incarcerated. Those are the only times that we will close the case. Any other time, you don't have to report your changes. You can wait until your renewal time. But if a change is reported that changes that eligibility in the household, we will leave your case open. The reason for these changes are studies show that when children are able to go to the doctor, there is no break in coverage. They're receiving the same consistent coverage. This allows you as a parent to take your child to the doctor, get all the screenings that they need, get their vaccinations. If they are sick, get their diagnosis. So this not only helps the families, but it also helps the state with cost sharing. If you're able to take your child to the doctor, you will not have to take them to the emergency room, or your child will not go without seeing a doctor because they're no longer eligible for this coverage. Does anybody have any questions right now with what I've said? Yes, ma'am.
So what about teen moms if they're pregnant and so they have that pregnancy Medicaid? Will that also continue after they're pregnant? They'll still get Medicaid?
So what happens is when there is a teen mom who is pregnant, if they are eligible, either citizens or eligible aliens, they will be covered under RKids A or B, depending on what category they fall under. So same, they will stay in that coverage even if anything changes. Now, we have two other categories. Pregnant woman, there is a category for 19 and up. And when women are pregnant, now this continuous eligibility is for children under the age of 19. So yes, they will be covered for the rest of their time if they're pregnant. Now, anybody, I'll just add that a pregnant woman, even at the age over 19, this applies to them too. If there is a pregnancy and there is a change in income or anything, they will receive coverage until the end of their 60th day postpartum. Yes.
Thank you.
That is also a change that was effective this year. Any other questions? Okay. So again, this is the core principle of this lies in maintaining the coverage to be uninterrupted. It's strategically designed to instill the stability of healthcare coverage. Again, this not only helps the families, but it does help the doctors, and it helps with cost sharing. It ensures uninterrupted coverage and facilitates a proactive approach in preventative health care. By removing those barriers and to regular access, children are more likely to receive their timely checkups, screenings, and preventative services, contributing to their overall health. I do want to point out that with continuous eligibility, you know, we do still have to look at income, and those do change every year. So every year that, you know, those do increase, and that is based on the federal poverty levels. Okay, these are the, oh, yes.
It says that you do not have to report changes in income or status because it'll be reassessed, but it also says that if you do report, that you would, it's possible that you could get more service based on the change, not always.
Correct,
less.
yes.
So you should report. I mean, I
Yeah,
guess I'm
so
confused
let's
of whether
say,
you should or you shouldn't.
Right, so you're not required to report, currently you're required to report that within 10 days, like if your child receives ARKIDS-A. But absolutely, if you have a child that's receiving ARKIDS-B right now, and they were approved October 1, and your child is getting ARKIDS-B right now, and you turn in a change and you say, I've lost my job. So we work that change today. So effective February 1st, your child is going to go into ARKIDS-A. In that scenario, we will go ahead and make the change effective next month because that's better coverage for your child. But on the flip side, if you would have reported that to us and now you're making more over the income limit for ARKIDS-A, we are not going to transition your child into ARKIDS-B next month like we would for ARKIDS-A. We're going to wait until 9/30 for your ARKIDS-B to close or ARKIDS-A to close, and effective ARKIDS 10/1 your ARKIDS-B will start. So we are going to make the transition if the coverage is going to be better for you, or maybe your child is going into TEFRA. They're approved for TEFRA, and right now they have ARKIDS-A or ARKIDS-B. Any change that's going to give your child better coverage, it will take effect the next month. But anything that is lesser or closure, we're going to wait until those 12 months are over.
It sounds to me like it would be better, whether you know it was going to be better for your child or not, to report.
I mean,
Because-
yes.
But it says you don't have to, but I guess it would be to the individual to encourage people to make any changes, because it could be better, but it won't be less.
Right, yes, and I guess, yes, I mean, that's a good point, because, yes, it's not required, but absolutely, it can result in better coverage, so we definitely, right, it's not gonna affect you either way, so yes, I understand, good point. And in our communication, we can kind of reflect that and let people know, because that's true. Any other questions on that? Okay, these are the exceptions to termination. One of these that I do want to bring up is that if we approve your child erroneously, if we made a mistake in our system, if there was a worker error, or if just something didn't work and we approved your child and they are not eligible, we do have to close that coverage. So let's just say that today we approved that child incorrectly, they're not eligible. And this is based off of an application that you turned in. If the application was turned in 1/1, we approved it today, then we will send you a notice saying, you know, your child's not eligible for this coverage, they're gonna close effective 1/31, basically. So that is something different. Again, death, agency error, erroneous coverage, child season to be a resident of the state, voluntary termination, and if the child turns 19. Again, like I said, incarceration is also a reason to close coverage. Any questions on those? No. While I said about the initial application, I do want to say that in your example about the change, if the change is turned in today, but your certification doesn't end until 9:30, that child's going to be eligible until 9:30. But if you turn in a renewal and we are assessing the eligibility and that child's over, that case will close because they've already received those 12 months. So it's based on your last approval or eligibility determination. So that is a little different than, turning in a change or us redetermining your eligibility at renewal. Okay, this just talks about the cost effectiveness of us doing continuous eligibility. And again, in Arkansas, we just started this January 1st, other than our kids being newborn coverage. Again, more points on the cost effectiveness for the continuous eligibility. This is how it helps children and families. Again, it provides stability and consistency, proactive preventative care, timely access to services, reduced administrative burden. This means, again, less times that we have to renew your eligibility, financial security, long-term health outcomes, and addressing health disparities. So in essence, the continuous coverage is a cornerstone for the health and prosperity of children and families. It represents an investment into the well-being and the future generations of our children. Yes, ma'am.
I have a question about the proactive preventive care.
Mm-hmm.
And I've asked this for myself, but it's happened with my daughter when I've tried to enroll her into any type of school setting, whether it be early Head Start or early intervention day treatment center. They always require for a well child visit to check either labs or to check their height, their weight, just, the general checkup. And I've always gotten a letter in the mail saying it's not covered through Medicaid. And when I've asked the doctor, she always tells me she needs to have like something she's being checked for, like an illness or something else. Otherwise, they can't bill insurance. So I was wondering why it says that they have regular checkups when that doesn't seem to be the case.
Okay, so I don't know on the billing, like when you've received that, have you discussed with Medicaid billing maybe like what it covers or why they didn't cover it or anything like that? Because I see that you said you did speak to the physician about it. Have you reached out to Medicaid billing? I can look into that and see, because it also depends on what category the child is in. But I'm curious to see if you reached out to Medicaid billing and if they were able to provide an answer.
Personally, when I've asked for myself, I've had the insurance tell me it does cover it, but then the physician tells me it doesn't. So there seems to be a disconnect and I just, we're just stuck in the middle.
With what you're told, with what the insurance is going to cover, and then what
Correct.
the doctor tells you?
Yes.
Okay, yeah.
And fortunately, my doctor, it's the same doctor we've been seeing since birth. She just doesn't bill us.
For the service.
Otherwise, we will get stuck with a bill.
Okay. That's definitely something, like if you can send that to Jason and we can look into it, because again, I know that different coverage of Medicaid will cover different services, but if there is a disconnect or your insurance says one thing and then Medicaid billing says something else and the physician, then that's probably something that they need to look at and see if there is a disconnect somewhere.
I definitely think there is a disconnect, because I'll have parents come in and say, my doctor's not covering my child's wellness checks. And when I called Medicaid, they said it does cover. And then when we call the doctor back, they're like, no, it doesn't. So I'm wondering, what's going on.
There's a disconnect there. Okay, I'll definitely look into that.
I know that Medicaid will only cover one wellness check a year for the child. Like even if the child didn't get their 2-year wellness check at 2, but they're like a month from being 3, it's still going to be their 2 year wellness check, and they're not going to be able to get their 3-year wellness check until a month before they turn 4. Like, it has to be in a 12-month cycle. Also, working for the school district, when you're trying to enroll your child and they're wanting a physical, they're wanting I can't think of what it's called, the whole physical, like height, weight, eyesight, all that. Any one that's dated within the past 12 months that your doctor can provide you without going into an appointment is sufficient for that, if that helps you at all. Like their last well check, if the doctor can give you that physical information, that should work for the school. I know that because working for pre-K program, and we require that, but it has to be dated within the last 12 months.
Like some places will ask for additional things like hemoglobin and blood, which, you know, I have to take to the doctor and then get an order for the lab. And then, so all of that. My daughter has to be sick. I have to wait for her to get sick in order to take her in.
So maybe some more clarity on the categories on what they cover, like on our side, what they cover and when they would cover that. I think that's probably a conversation that of how we can make awareness of that.
Yeah, I think it's really important, and it should be a necessity of being able to take them to the doctor when it's required by the school. That's kind of stopped me sometimes in trying to enroll her, because I'm just kind of waiting for her to get sick, and like I have to make sure the timing is right and make sure that I have all of the documentation I need from the school to take it in all at once, and then all the other questions I have about, you know, everything else. So it's kind of a hassle sometimes.
Right. Okay.
You stated on one of the exceptions to termination was incarceration.
Mm-hmm.
So will the new approach to reentry apply to that?
Yes, so, right. So with the new reentry, the dates that they're looking at would be, 90 days going in, 90 days going out, but, so it would apply after that.
Okay.
So let's say that they're there, a year, then after that 90 days when it would close. But right now, the Medicaid should close the day that child is incarcerated. And then there's other areas where they're, if they go to a group home, if they go to the hospital, we definitely turn it back on. But just, if they're going to DYS, it will stop that day. But whatever their needs are in DYS, they're covered.
Any other questions? All right. Rose, thank you so much.
Thank you.
All right. For those of you who are new, you have information packets when you arrive. There's a form in there for you to sign that will help you get reimbursed for your for your transportation costs if you traveled here any amount of distance, or even childcare reimbursement if that's part of your being here. So don't forget to sign those forms. AFMC handles all that. All they need is your signature on those forms. Also, remember, if you haven't, especially new members, log into your Medicaid Client Voice Council emails. There will be some directions in there to set up, and also in your packets, new members, is your information about passwords and logging into your email account. So if you haven't been doing that already, please do that. So the next Medicaid Client Voice Council meeting is scheduled for the third Tuesday in March, which is March 19th. That is spring break. Are there any preferences strongly moving the meeting up or back? Because we probably won't do it, I guarantee we won't do it on that Wednesday of spring break. So if there is any strong feelings one way or the other, as you look at your schedules, let me know that. When we have our agenda meeting, I will talk with DHS staff because they may have some preferences as well, and we'll decide whether to move it up 7 days or back 7 days in the month of March. All right. We've never finished this early before. You guys breezed. I appreciate you driving in this morning, especially those of you who had to battle fog, maybe got here a little late because of that. I know some of you travel great distances, several from Northwest Arkansas. We really appreciate your attendance here at these meetings. Please travel home safely and we look forward to seeing you in a couple months. If you were given instructions to send me emails and you don't have my email, which you should, but just come up to me after the meeting. I'll give you my email, and we can take care of business together online.